It's 2 a.m. and your pager goes off. Doc, the patient in room 404 is having chest pain. This is one of the pages that requires immediate action, not after you finish what you are doing and not after you place a few orders from the computer. Chest pain at 2 a.m. deserves your attention now. Nobody wants to miss a STEMI, nobody wants to miss PE or dissection. Nobody wants to ignore the early signs of something catastrophic. But immediate action does not mean blindly ordering everything in the chest pain order set. This is where chest pain at 2 a.m. becomes dangerous. Here are 5 mistakes I commonly see that can hurt your patients. Mistake number 1, treating chest pain as an order set before seeing the patient. When the nurse calls at 2 a.m. and says the patient is having chest pain, the wrong reflex is to simply order an EKG, troponins, a chest x-ray, D-dimer, or whatever else lives inside the chest pain order set. That's not an evaluation, that's clicking boxes. Instead, my response is always, please get a stat EKG and a full set of vital signs. I'm on my way to assist the patient at bedside. At 2 a.m., those 3 findings, current vitals, a stat EKG, and bedside assessment must happen in parallel. And please do not get tired of ordering EKGs. Even if the pain sounds pleuritic or reproducible, even if the patient swears it feels like reflux, even if an EKG from earlier was normal. If the pain returns, worsens, or changes, repeat the EKG. But ordering the EKG is only half the battle. You must read it immediately. One of the most dangerous situations in medicine I see often is a stat EKG that sits unreviewed in the chart for 30 minutes or longer while an active STEMI evolves. If you are uncomfortable reading EKGs, ask for help early. Never solely rely on the machine interpretation, please. And while the EKG is printing, look at your patients. Are they diaphoretic, pale, tachycardic, or in respiratory distress? Is the pain a crushing or pressure in nature, or is it sharp and tearing? Listen to the lungs and heart. Check for chest wall tenderness or size of volume overload. Then let that bedside assessment drive your next steps. Do they actually need that D-dimer, troponin, or chest x-ray? Those decisions should only be made after you know what the patient looks like, what the vitals show, and what the EKG reveals. Ordering tests is not the same as evaluating a patient. Safe chest pain care starts at the bedside. And by the way, if you take overnight calls like this, subscribe. This channel is built for exactly these 2 a.m. moments. Now let's move to mistake number 2. Treating the pain before understanding the cause. The 2 a.m. reflex is to make the patient comfortable, which is good, but this can be a dangerous trap. No pain medication should be prescribed for acute chest pain before you have personally assessed the patient. Your choice of analgesic is not just about comfort, it is a diagnostic and therapeutic decision. For example, a musculoskeletal chest wall pain responds best to NSAIDs, where the ischemic pain requires nitrate to address the underlying supply and demand mismatch. Treating both with a blanket order of an opioid masks the underlying pathology without fixing it. Furthermore, narcotics should not be automatically used for chest pain. This is particularly important when ischemic chest pain is suspected. Use nitroglycerin instead. The current guidelines advise against using narcotics in these patients unless the ischemic chest pain persists despite maximally tolerated anti-ischemic therapy, say nitrite, beta blockers, and in this case, the patient should be taken to the cath lab emergently. The patient's symptoms and EKGs are a live window into what's happening into the coronary arteries right now. If we give narcotics and the pain stops, we simply silence the alarm while myocardiums continue to infarct. So never blindfold yourself at 2 a.m. Assess the patient, identify the likely mechanism of the chest pain, and target the cause, not just the symptom. Let's move to mistake number 3, using troponins without knowing what questions you are asking. Let's be completely honest here. High sensitivity troponins is often ordered regardless of whether ACS is truly suspected or not. It is pure defensive medicine, and in a high litigation environment, it is understood, right? But if you are going to play the defensive game, you have to play it right, and you have to know how to handle the data you unlock. Instead, what we do, we frequently fall into two real world traps. Trap 1, checking a single set to rule out. Ordering a single high sensitivity troponin and walking away when it's negative is a dangerous half measure. If you are genuinely ruling out acute coronary syndrome, a single negative set is not enough. Instead, order high sensitivity troponins every 3 hours, at least 2 times, and the first one stacked. If both are negative, then serial EKGs are clean and the clinical picture is stable, you are good. You have safely ruled out an acute coronary syndrome. Trap number 2, letting the lab do the thinking. The opposite error here is ordering the lab just to look at a number without a clear clinical question in mind. High sensitivity troponin is exactly what the name implies, highly sensitive. It is a marker of myocardial injury. It tells you myocytes are stressed, but it does not tell you why. Is it from a true coronary occlusion? Is it from supply and demand mismatch, or from conditions with chronic troponin leak like heart failure or end-stage renal disease? This is exactly why your history, your exam, and your EKG should have guided you from the very beginning. When that number comes back ambiguous, the lab cannot save you. You have to look at the clinical trajectory of the patients, the EKG, to decide if this is an evolving acute coronary syndrome or just baseline chronic disease. Do not let the lab do the clinical reasoning for you, please. If you order troponins defensively, know exactly what a positive result means for that specific patient before the blood is even drawn. Let's move to mistake number 4, ordering a D-dimer because you are nervous. At 2 a.m., fear is a terrible clinician. You are tired, you may be flying solo, the voice in the back of your head is start whispering. What if it is a PE? So you order a D-dimer not because the story clearly points to PE, not because you calculated the pretest probability, not because the result will clearly change management, but because you are nervous. That is how D-dimer gets misused. D-dimer, as you know, is not a general screening test for chest pain. It is not just to be safe test. A positive D-dimer does not diagnose PE. It often just pushes the patient toward a CTA of the chest that may not have been needed in the first place. I recently admitted a patient with pyelonephritis and noticed she had a chest CTA. When I asked why it was ordered, the answer was because the D-dimer was positive. But she had no chest pain, no shortness of breath, no real PE story. So the better question was not why was the CTA ordered, the better question was why was the D-dimer ordered in the first place? In hospitalized patients, D-dimer is commonly elevated from infections, inflammation, age, cancer, surgery, trauma, and many other reasons. A positive result is not surprising, and it does not automatically mean PE, as all of you know. So before ordering it, pause and ask, am I truly considering PE? What's the pretest probability here? Is the patient low risk enough that she can stop the workup? What would a negative D-dimer actually in the PE evaluation? And if the patient is high risk, why am I ordering a D-dimer instead of imaging? D-dimer is useful when it answers the right questions in the right patient. It is harmful when it's used to treat out anxiety. At 2 a.m., do not order a D-dimer, please, just to be safe. Be safe by thinking first. Let's move to mistake number 5, letting aortic dissection fall off your differential. Before you call it ACS and start heparin, pause for 1 second and ask, could this be a dissection? This does not mean that every chest pain requires a CTA of the aorta to rule out that. It means dissection should not disappear from my thinking at 2 a.m. The danger is not only missing the diagnosis, the danger is treating the wrong diagnosis. Anticoagulation may help in ACS, right? But if the patient actually has an acute aortic dissection, anticoagulation can be catastrophic. And if the dissection flap extends into a coronary artery, the EKG may even look like a STEMI. So before you commit to the ACS pathway, ask yourself, does the story fit? Sudden severe pain that's maximal at onset should make you pause and think about dissection. Tearing or ripping pain to the back should make you also pause. Chest pain with syncope, neurologic symptoms, limb ischemia, pulse deficits, hypotension or shock should make you pause. A history of uncontrolled hypertension, non-aortic aneurysm, bicuspid aortic valve, Marfan syndrome, other connective tissue disease or cocaine use should make you pause as well. When that story is in front of you, slow down, check blood pressures in both arms if feasible, look for pulse deficits, listen for a new aortic regurgitation murmur if you can in a noisy environment, look for neurological findings or signs of perfusion. A chest x-ray may show widened mediastinum, but a normal chest x-ray again does not rule out dissection. Bedside echo can also be very helpful when available, especially if the patient looks unstable or appears to have a STEMI, but the story feels wrong. You may see a pericardial effusion, aortic regurgitation, or sometimes even an intimal flap. And remember this, a positive troponin does not rule out dissection. Troponins can rise if the dissection involves the coronary arteries or causes myocardial injury, so do not let a positive troponin automatically lock you into ACS. The key is not to order CTA aorta on everyone. The key is to ask the question before you give the wrong treatment. At 2 a.m. before you reflexively treat chest pain as ACS, make sure the story is not trying to tell you something more dangerous. To conclude, a 2 a.m. chest pain is not an order set. It is a bedside assessment. Start with the patients in front of you, current vital signs, a stat EKG that you actually read, not just leave it at the chart, and a focus exam. Then let the story guide the rest. Troponins, D-dimer, CTA, chest x-ray, nitrates, morphine, NSAIDs, none of these should be a reflex click. They should answer a clinical questions. The goal is not to order everything. The goal is to quickly identify what can kill the patient, avoid treatments that can hurt them, and keep reassessing when the story changes. In the end, if you work nights, resident, hospitalist, nurse practitioner, PA, or nurses, this channel covers exactly these 2 a.m. calls and scenarios. I also write the longer version of each of these scenarios on my Substack. Link is provided in the description field. Stay safe tonight, and thanks for watching.